Hi everyone. Beginning with the very first chapter and the foundation that we have for pathology, and that is cell injury. Now, when we talk about cell injury, all of you are very well versed with certain names, that is necrosis, apoptosis, the pigments, accumulation, but it's just not limited to that. The maximum advances and updates have also happened in this chapter. So be it the newer cell deaths or aging or some very interesting topics have been added, and we need to now cover this chapter in a holistic approach, considering the old and the new topics and keeping in mind that we also have to integrate it with all the recent updates and the other subjects on how a clinical question can come out of it. So yes, taking forward this journey of pathology with all of you and starting with the very first chapter, cell injury. So let's start with our utmost basic and let's talk about the causes of cell injury, which we will be covering in the form of one-liners. So first question, what is the most common cause of cell injury? Why does injury happen? And the most common cause is going to be hypoxia. When we say hypoxia, what is the definition of hypoxia? Hypoxia is a decrease in the oxygen at the tissue level, right? So basically, whenever the oxygen level goes down in the body, the process of cell injury is going to begin. So why does hypoxia occur? If someone asks us what is the most common cause of hypoxia, so oxygen is going down because of ischemia. What do you understand by ischemia? Ischemia means that the blood supply has been somewhere hampered. So there is some problem that has happened in the blood supply, be it maybe because of atherosclerosis or any other reason. So when the blood supply is going to go down, that is when oxygen will go down. The next question, which is the cell which is most sensitive to hypoxia, meaning which is going to give up at the earliest way as soon as hypoxia happens, and that cell is going to be the brain. You can say the CNS, the brain, or you can also call it the neurons. If you want to talk about cells, then of course the neurons. And let me tell you, there are different opinions on it. Some books mention that they can survive 2 to 4 minutes. Some books mention they can survive 3 to 5 minutes. But yeah, that's the upper limit. If this much of minutes of hypoxia occurs, the neurons are going to give away. See, make it a habit now, since this is your first chapter. I have to give you advice on how to study also, right? Taking forward path and micro. So please remember the cell most sensitive to hypoxia. If you've read anything which is the most sensitive, it is your duty now onwards to also know which is the cell which is the most resistant. Means which is the last man standing. No matter how much hypoxia occurs, that is a cell which is going to stand. And what is that cell going to be? That is a fibroblast. That is a fibroblast. So you started your journey with 4 one-liners. First one, most common cause of cell injury. Why is cell getting injured? Because the oxygen levels are going down, hypoxia. Next, what is the most common cause of hypoxia? Because the blood supply is not there. Next question, which is the cell most sensitive to hypoxia? That is the brain, the neuronal cells, and the cell most resistant to hypoxia, fibroblasts. Having said that, now let's begin with our actual journey and let's start reading about how this chapter is going to go forward. Before that, let me give you an overview about this chapter. So please remember that whenever I will talk about cell injury, so, many of you know that cell injury is of 2 types, reversible, irreversible. So, how are we dividing this chapter? What was the most common cause of cell injury? Hypoxia. So, whenever any hypoxia or any injury happens, what do you think? Is your cell going to give away? Is your cell going to die within seconds? No, of course not. The first thing that your body is going to do is adaptation. Your body will adapt first. So there's a topic known as how does the body adapt? Cellular adaptations. After the adaptations are done, the next thing that your body, so what if you adapt? Very good. I'll be very happy if I adapt to any situation. But what if adaptation fails? Then obviously I'm not too happy about it. That is when the body has entered into reversible cell injury. Body has entered into reversible cell injury. Now, if you treat the patient, as they are saying, everything is reversible. If the patient will get the treatment, he will be okay. But if he doesn't get treatment, if the injury continues, if everything continues as it is, you're not giving treatment to the patient, he is now going to enter into irreversible cell injury. He is going to enter into irreversible cell injury. And what is the final step after irreversible cell injury? Unfortunately, the cell is going to die. So there is cell death that is going to happen. And these are what all of you know as necrosis, apoptosis, and all of those cell deaths that we study. So yes, this is exactly the entire chapter. The first part of the chapter will be where I will be teaching you these injuries. I will talk about reversible cell injury. I will talk about irreversible cell injury. Then in the end, I will also talk about what are the adaptation processes that your body has. And also I'll be talking about all the different cell deaths. So I hope you've got an overview of the chapter. So let's begin. Let's begin with the very first topic, and that is reversible cell injury. Yes, so I want to start off with what all of you know. What is the most common cause of cell injury? And that, as all of you know, is hypoxia. When I say hypoxia, you all know it's a decrease in oxygen. I'm going to take you, if you think I'm starting with basics of MBBS and pathology, no, I'm going to take you back to school. Remember, we studied that whenever the oxygen concentration goes down, which is the first organelle which is going to give up? And that is mitochondria. So the first thing that is going to happen is mitochondrial dysfunction, right? Mitochondrial dysfunction happens. And taking you way back to your really junior classes, what is mitochondria? Mitochondria is the powerhouse of the cell. Remember, mitochondria makes all the ATP for all of us. But now I'm saying that there is a mitochondrial dysfunction that has happened, which means that the mitochondria is not going to function properly, and there is a decrease in the ATP production. Now guys, be very, very cautious over here, because now I'm going to tell you some PYQs alongside. So the first question that has come in the paper is that what is the first change of cell injury? Okay, so what is the first change? You can see that is a problem in the mitochondria. Mitochondria going bad. Mitochondria not working means ATP production gone down. So what next? Because the ATP has stopped working, now there are three things that are going to take place in a cell. Most of the students come back to me saying that we can't understand this entire process, how these three things are happening. So I'm going to give you one trick over here, and that will help you learn the entire chapter so smoothly. So what is the trick? Think logically. If I draw any cell in front of you, what all will you draw in a cell? If I say draw a cell, what will you draw? Number one, you will draw the cell membrane. What is a cell membrane made up of? Cell membrane is made up of phospholipids. So that's the first thing you will draw. Next, you will draw the nucleus in the center. So yes, the next thing that you shall draw is the nucleus. And what else? Then in between, you will draw all the proteins. You will draw all the proteins. So if I say what are the three backbones of a cell? The three backbones of a cell are going to be, number one, we have the membrane, which is phospholipid. Then we have the proteins, and then we have the nucleus. Well, having said that, so now when I'm saying that the ATP production is going down, that means these three backbones are going to give away. So let's start the first part, and this I'm going to take in the form of three parts on three separate slides, so all our concepts are in a place. Let's begin with part number one. What is happening? So let's continue what has happened in the first part, and that is failure of a pump. Please remember, there is failure of, do you know any pump which needs ATP and now I don't have ATP? So what is that pump? The sodium potassium ATPase pump. So there is a failure of the sodium potassium ATPase pump. So what am I going to do? I'm actually first going to draw a pump. Let all of us draw a normal pump. Let me divide this pump into a cell into two parts. Let us first draw the normal sodium potassium ATPase pump, and then we'll talk about the failure aspect that has happened. Okay. So when I talk about sodium potassium, what do you know? What is exiting? What is entering? Very confusing in physiology also. So remember, it is the three sodium ions that are going to exit and the two potassium ions that are going to enter. So sodium is going to go out and potassium is going to come inside. There are so many mnemonics which I've heard students learn about this. One very famous mnemonic is Nokia. I have heard Nokia as a very famous mnemonic where students understand or learn that sodium is going to go out. So N for sodium, O for out, and potassium is going to come inside. So K is inside. A very, very famous mnemonic amongst the medical students, that is Nokia. How I have learnt it was P for P. Potassium penetrates. Potassium is going to come inside. Another way of learning. So potassium penetrates. That is normal. So tell me something. Where do you have more number of ions? See, 3 sodium have gone outside and only 2 potassium have come inside. So at the end of the day, more number of ions are outside, right? Now let's talk about the third part. Sodium done, potassium done. What about ATPase? So this entire pump actually required ATP. So when the ATP was working fine in the body, everything was all good. Now I'm saying ATP is not being produced. If ATP is not being produced, you are talking about a state of failure. If you're talking about failure, that means the pump is going to be reversed. Think of reversal. See, what was Nokia? Sodium was going out. So now opposite. Now sodium is going to come inside. 3 sodium are going to come inside. And potassium was initially penetrating, but now potassium goes outside. So 2 potassium is going to go outside. When I'm saying failure, in simple words, you will learn it as reversal. So if normal was Nokia, failure is the opposite of Nokia. So now tell me, where are there more ions? See, now 3 sodium have gone inside and 2 potassium are outside. Where are there more ions? Obviously, there are more ions inside the cell. Go by your basics of physics and chemistry. Now, where do you think water is going to go? If all the ions have gone inside, common sense, water is also going to go inside. So there's a water influx that happens, guys, and that is what is going to tell you the water balloon theory. I call it the water balloon theory. What is water balloon? So see, water is going inside. How do you think your cells are going to look like after a while? Your cells are going to look like a nice water balloon, because you fill a balloon with water, the balloon keeps growing. But there will come a time where the water balloon will burst. You can't keep filling it with water. After a time, the water balloon will burst. So initially it will become big in size, and after a while it will burst, right? Same way is happening with the cell. Initially it is becoming big in size. So can I say this is responsible for the very famous cellular swelling? This is responsible for cellular swelling. And why is this cellular swelling happening? Why is it becoming a water balloon? Because of water entering inside it. So that is referred to as hydropic change, right? And this becomes your PYQ next that you have. So what does your previous year question say? It says, or it asks you, which is the first morphological change of cell injury? Which is the first morphological change that occurs in cell injury? And let me tell you guys that it's all about reading the question carefully, because over here only one word has changed. See, if I would have asked you the first change of cell injury, what would you have told me? Only the word first change of cell injury would have been asked. You would have told me mitochondrial dysfunction. Now, instead of asking you change, I have asked you first morphological change. So the first what is morphology? Morphology, size, shape, structure, all of that, right? So if the morphological change is asked, then you are going to answer this. You shall be answering the cellular swelling or hydropic change. Okay, so the story is not over. Right now, you've just understood that, okay, the cell has started becoming bigger and bigger. So what all have you studied? The cell has only undergone a cellular swelling. What else? More and more water is going to enter. More and more water is entering. Don't you feel organelles will also swell up? There is endoplasmic reticulum swelling. All the organelles will also start becoming bigger and bigger like a water balloon. Okay, next, let me see. There are many cells in the body which are going to have tiny projections called microvilli. Many cells in the body have something called microvilli. Don't you feel if a water balloon is expanding, or if a cell is expanding, if a cell is becoming bigger and bigger, don't you believe that these microvilli are going to be flattened? Because the surface area will start increasing. So gradually they will start getting flattened. What else? More and more water enters. Initially the cell was looking like this. Now water keeps on entering. There's too much of water that is going inside from everywhere over here. Don't you feel your cell will start making little bit of blebs, little bit of projections, because it's trying that, okay, till whenever I can hold the water, I will hold. So what is your cell started making? Your cell has started making cytoplasmic blebs. Cytoplasmic blebs have started to be formed. And finally, there comes a time when the cell says, enough, so much of water is coming inside me, I am having a problem. So finally, there is a formation of something known as myelin figures, and exactly what I'm going to teach you next. But what I want all of you to remember is that all of this that had happened, all of this has happened because of a failure of a pump. That sodium potassium Nokia pump has basically failed. That is why water everywhere. Water has resulted in the swelling, water has resulted in the microvilli flattening, in the cytoplasmic blebs, and finally myelin figures. So your question will be, what is myelin figures? So let me show you a particular picture out here. Have a look at this. The first image of pathology that I'm showing you. It's quite unfortunate that I myself say that pathology is the colors and it's about pink and blue and whatnot, and the first image that I share with you is a black and white photo. But having said that, whenever I show you a black and white microscope in a pathology slide, means we are talking about an electron microscope. What we have out here is an electron microscopic picture. Here onwards, I will be writing it as EM. Now, what do I see? I can see something going round and round. If you look very carefully, it's showing you this kind of an appearance. So that is how you identify a myelin figure. Please remember, a myelin figure is described as concentric lamellations, very famously written in the MCQs. It is written as concentric lamellation. So what would come to your mind is, what is it made up of? It is made up of, if someone asks you the question number 1, if someone asks you what is the composition, it is made up of phospholipids and calcium. I am repeating, it is made up primarily of phospholipids and a little bit of calcium. So now look at your question very carefully. If they say myelin figures are made up of phospholipid or calcium or both, you answer both. But if they ask you which is the predominant composition that you have, the predominant one is obviously going to be phospholipids. Means phospholipids coming from where? Phospholipids are always present in the membrane, right? So indirectly, if this is a question that has come in your previous years, again, I'll write a PYQ over here. If they ask you that phospholipids, or in other words, myelin figures are derived from what? Myelin figures are derived from the membrane of a cell. See, the first backbone I have broken. The membrane phospholipid I have broken. Okay, the next thing, which injury am I talking about? That is question number 2 that you have. So obviously, myelin figures are seen in reversible cell injury. But next they will ask you, are they also seen in irreversible cell injury? Your answer is yes. Please remember, as I go forward and I will teach you irreversible cell injury, I will also teach you myelin figures once again. So what's the difference between reversible and irreversible? Remember, in reversible cell injury, myelin figure formation just starts. But in irreversible cell injury, there is an increase in the number. So that means, I'm just giving you a random number. In the starting, in reversible cell injury, if you have 5 myelin figures, in irreversible cell injury, you will have 50 myelin figures. So if a question comes, myelin figures are seen in reversible, irreversible or both, and your answer is going to be both. But where do you see more of myelin figures? More are seen in irreversible. Or where does it just start off? It is seen in reversible. I hope that is clear. The image is also clear. Coming all the way back. Now, if you remember, this is where we were. Because of ATP going down, the first problem that happened was failure of the sodium potassium ATPase pump, right? However, that's not the only thing. Now I'll tell you the second problem. The second and the third. The second problem is, see, what have you damaged up till now? Till now, I have damaged the phospholipids. The phospholipids are gone. What do I have to damage next? I have to damage the nucleus. I have to damage the proteins. Only then my cell will be injured. So the second and the third point is exactly what I'm going to go on to. So let's begin. The second problem is that, why is all of this happening? Hypoxia? Everything starts off with hypoxia, you agree? So now tell me something. If oxygen is not there, which kind of glycolysis will occur in the body? Go back to your biochem. The glycolysis that will happen will be anaerobic glycolysis. You are going to see the presence of anaerobic glycolysis. Tell me one byproduct. What is the byproduct of anaerobic glycolysis? Lactic acid, pyruvic acid. So in other words, you want to say that the pH is going to be down. The pH is going to be acidic. That is what you want to tell me? What happens in the body when the pH goes down? The nucleus starts giving away. There is nuclear chromatin clumping. Nuclear chromatin clumping is what is noticed. So has the second backbone been damaged? Have I managed to break the second backbone and that is the nucleus going down? Yes. Finally, I have to talk about the third backbone. Now, do you know, because of all of this, what happens? I'll draw one thing. Which organelle does this remind you of? Go back to your school. Which organelle is this? Endoplasmic reticulum. And on top of this endoplasmic reticulum, if I draw a few dots, if I draw ribosomes, if I draw these ribosomes, what is going to happen then? Because of these ribosomes, I call it rough endoplasmic reticulum. Yaad aaya from school time that there's an endoplasmic reticulum with ribosomes, so that's rough endoplasmic reticulum. Fine. Now, because of all the oxygen not being there, ATP not being there, these ribosomes get detached. These ribosomes are going to get detached. Now tell me, no ribosomes, no rough endoplasmic reticulum, what do you think is going to happen to the protein synthesis? It goes down. Third backbone gone. There is a decrease in the protein synthesis that basically takes place. So protein synthesis is gone. And whenever there's a decrease in the protein synthesis, what compensates is an increase in the fat production. So there is going to be a fatty change that I'm going to see in the organs. That is what you very commonly know as things like fatty liver and all of those. So basic concept is that because there was a decrease in this ribosome and ribosomes are getting detached and the protein synthesis has gone down, compensatory, the fat production and deposition increases. And that finishes off all your 3 steps of reversible cell injury. Let's do a recap. The first one was that the pump was failing. The second one was because of anaerobic glycolysis, the nucleus was going away. And third one was that there's a decrease in the protein synthesis, and that happens because the rough endoplasmic reticulum was getting affected. I hope everyone has understood reversible cell injury, because guys, whatever I have studied up till now is reversible. Means anything you want can get back to normal. You just need to treat the patient. You treat the patient and everything will be fine. How does this question, if you remember, how did this question come to you guys in your second year prof exams? Because this was a very, very famous slide that came as a pass-fail question in your vivas. And that was, they gave you that there is something to do with the kidney. So that is a history that was given to you, that a kidney specimen was given. And how did they define it? Suddenly you're seeing that the cells of the kidney are not looking pink. Pathology is all about pink and blue, right? But over here, the cells are looking very, very white. Why are they looking white? Because somewhere water has entered them. This is water change, hydropic change, the water balloon change. That is why the cells are looking so white. And what was this known as? This was given a name called cloudy swelling in the kidney. This was given a name called cloudy swelling in the kidney. I hope everyone has analyzed it, understood it. So this is all about reversible cell injury. Now the story is going to go forward. As I told you, first we were talking about injury. The first injury was reversible cell injury. If I cannot correct it, we are going to go forward, and now we will discuss irreversible cell injury. So what is happening now? But there will be a question in your mind. How does this go forward? And how do you get, you'll ask me that, ma'am, how do you get to know that, okay, till now it was reversible, now it has become irreversible? So if you ask me, what are the 2 defining moments? What are the 2 defining moments when you decide that, okay, reversible cell injury has now become irreversible? When is that defining moment? Remember M&M. What is M&M? It's not the famous M&M chocolates that I'm talking about, but M&M means whenever there is a severe membrane damage. Whenever there is a severe membrane damage, that is when I say, okay, membrane damaged, nothing can be done. Now it's irreversible. And second, there is something called as severe mitochondrial damage. So I actually realize that mitochondria is quite an important person in this entire chapter. And let me tell you, not just an important person, mitochondria is the hero of this chapter. Everywhere I talk about important organelle, I will talk about mitochondria. So tell me, till now, where have I spoken about mitochondria? Didn't I tell you that the first change to happen in reversible cell injury was The first change was mitochondrial dysfunction. So mitochondria was undergoing a problem. Here also I'm telling you, when do you decide that there is irreversible cell injury? Which organelle undergoes a problem? Mitochondria undergoes a problem. So whatever I have written, let me draw it out. Let me draw a cell over here. So for example, this is a cell and I have drawn this cell membrane, the outline, the cell membrane has been drawn over here. But now I'm saying that when this cell membrane will undergo damage, when this cell membrane is going to undergo a damage, that is when the problem will arise. So what did I teach you? M&M, if membrane undergoes damage, which injury have you entered? We have entered into irreversible cell injury. And as soon as, imagine there was a barrier and that barrier has broken away. So remember, there was a barrier over here and the barrier has broken away. So that basically means everything is now getting inside. Everything will be allowed to get inside, but I am interested in calcium. Any reason? Why is my love for calcium coming out over here? See, it's a barrier. If I open a door, everyone is allowed to come inside, but I'm only focusing on calcium. So I'm going to tell you a little bit of physiology correlation over here. So listen to that. See, you know what God decided? God decided that if this is a cell, I am going to keep 99.9% of the calcium outside. Most of the calcium was kept extracellular. Any reason why did God do that? Why was all of the calcium kept outside? Because God knew that if I keep calcium inside, if I bring all the calcium inside, calcium is a very important cofactor for the enzymes, right? So if calcium is got inside, all the enzymes will get activated. I will kill my own self. I don't want that. I don't want calcium should come inside my body. Calcium should start killing start activating my enzymes and should kill me. No, not happening. So God said, keep all the calcium outside. Keep very, very little 0.1% calcium inside. Keep everything outside. But now that barrier has broken. So now calcium says that I am going to run inside, right? And that is where the problem starts. This calcium will run inside to which organelle? And the organelle, the hero of this entire story, that organelle is going to be the mitochondria. So calcium runs inside and goes to the mitochondria. So here I see calcium sitting. Here I can see that calcium has come and has sat inside. Do you know what is this known as? This is known as the amorphous flocculent densities. This is referred to as the amorphous flocculent densities. And what do I again mean by that? If I ask you 3 questions on amorphous flocculent densities, let's see how many of you have been listening. Question number 1, amorphous flocculent densities, what is it made up of? What is the composition? The composition is calcium. It is calcium which is coming inside. Question number 2, which organelle is it coming and sitting in? The organelle is going to be mitochondria. Question number 3, which injury am I talking about? The injury is irreversible cell injury. 3 questions about amorphous densities and they are made up of calcium. So now I want to tell you how the examiner will confuse you over here. This is a very catchy kind of a point. Listen to me very carefully. So examiner doesn't give you all these names like myelin figures and amorphous densities. He just picks up one thing called calcium. Examiner says calcium is present in which injury? So you will learn that calcium, as I am writing over here, do you see that in irreversible injury? Yes, calcium is seen in irreversible injury. What do you call it? You call it amorphous densities. Was calcium seen in reversible cell injury also? Can you recall? Going all the way back, was calcium seen somewhere in reversible cell injury as well? Yes, in the myelin figures. In the myelin figures, the calcium was seen. So now if I ask you, calcium is seen in which injury? Calcium is seen in every injury. But more amount of calcium is seen over here when the barrier will break. When this barrier is going to break, more amount of calcium is seen here. And what do you call it? Amorphous flocculent densities. Most important previous year question. Okay, moving on. Next, we move on to what else did calcium do? This calcium decided that now I have got all the license to activate the enzymes. I am going to activate enzymes. That is why God had kept me outside. But now I am inside. I will activate the enzymes. And there are 3 enzymes. Think, which 3 enzymes will it activate? You guys know. What is the backbone of a cell? 3 things. Phospholipid, nucleus, proteins. Break them. Break them. So which enzyme are you going to activate? For phospholipids, you will activate phospholipase. For proteins, you will activate protease. And for nucleus, you will activate Nuclease. Like I told you, remember the 3 backbones and you're sorted. Phospholipids, phospholipase, proteins, protease, nucleus, nuclease. As simple as that. But there's a catch in the story. Do you think nucleus, now nucleus, if I talk about the nucleus, what does nucleus have? Your parents have given you everything in your nucleus. Your parents have given all the DNA, chromosomes, genetic material in your nucleus. Can this one tiny little enzyme one fine day come and just break it within seconds? No, not happening. It can't break in seconds. It will be stepwise breakage. So that is the next question that they ask you. What are the nuclear changes? So what are we going to do? We are first going to draw a normal cell. Before I start showing you the diagrams, let me explain the theory. This is a normal cell and this is a normal nucleus inside it. So we label this as a normal cell. Now, when the nuclease enzyme has come and has started trying to break the nucleus, what is the first thing that is going to happen? The cell remains the same. There's no change in the cell. But look at what has happened to the nucleus. Now, you will all appreciate this with me, that over here, the nucleus is not only becoming smaller, but it's also becoming darker. Right? So, what is this step known as? So, what will you say? There is going to be something called as pycnosis. There is pycnosis. What is pycnosis? Pycnosis is nuclear chromatin getting condensed. Nuclear chromatin getting condensed. When I say condensed, it means it's becoming limited. When I say limited means, what did you notice? We noticed that there is a nuclear shrinkage. Can we see the nucleus is, when I say it's condensed, it means it's becoming smaller. So there is a nuclear shrinkage that is happening. Moving forward, what is the next step? Now in the next phase, I realize that the nucleus has started breaking. The nucleus has started breaking into, it's like a bomb blast happening. Tiny, tiny pieces it is breaking into. What do I want to call it? That is known as karyorhexis. Everyone, don't just mug up things. Try to know the name and you'll understand everything. See, karyo means what? Karyo means nucleus. And what is rhexis? Rhexis means breakdown, fragmentation. So what is happening in karyorhexis? There is nuclear fragmentation. The nucleus has broken into tiny, tiny pieces. And finally, what's the last step that is going to occur? The last step is, do you see a nucleus? Am I drawing a nucleus over here? No, I'm not, because the last step is said to be karyolysis. Karyolysis. What is karyolysis? So again, karyo means nucleus. And what do I mean by lysis? Lysis means dissolution. The nucleus is going to get dissolved. It is gone. So what are the 3 steps? And we very famously learn it as PKK. They tell you, this is a previous year question. They will tell you to arrange it in an order, in a sequential order. And guys, I'm making it a habit that I mark PYQ because we all know the importance of PYQ. We know towards the end, when time is limited, we can't go through everything all over again and again for our revision. These PYQ bullets are what you're going to revise. So they tell you to arrange the nuclear events in a sequence. So PKK, the first one is going to be pycnosis. The second one is karyorhexis. And the third one is karyolysis. So now that we've studied the PKK, let us move forward and go ahead and look at this image in the form of an image-based question. So look at this over here. Here you can see the normal nucleus. Further, what you can visualize over here is how the nucleus is becoming a little smaller and condensed. So you'll call it pycnosis. Next, you can see how the nucleus is breaking. So you'll call it karyorhexis. And finally, the nucleus has dissolved out, and that is karyolysis. So remember, as I said, PKK is going to be your mnemonic. Well, having said that, guys, coming all the way back, what did I promise to you? That if you want to finish irreversible cell injury, you should definitely have been able to do the 2 M's. You should have a severe membrane damage and you should have a severe mitochondrial damage. And look at both of them. The membrane damage also I did, and the mitochondria. How is mitochondria damaged? By the amorphous densities, right? All said and done, irreversible cell injury also over. Now we move on to the last part of this particular flow chart, and that is going to be the cell deaths. Now remember, cell deaths are everyone's favorite: necrosis, apoptosis. So first we'll go to the cell deaths which everyone knows. We'll start off with the most common cell death, that is necrosis. Then gradually we'll move ahead and we'll talk about the new cell deaths and necroptosis and all of those. So let's start with necrosis. Let's start with our basic. What is the definition of this cell death, that is necrosis? So the first thing, I'll I'll write down 2-3 words of this definition which are very important. So first and foremost, necrosis is a pathological cell death. Now, when I say pathological, this is very important to know because that means it will only occur in some diseases. I can never say necrosis has occurred normally. No, it has occurred in some disease like a heart attack, or it has occurred in TB. TB is caseous necrosis, right? So some or the other infection or disease, some pathology I will always tell you. And the next part of this definition is that it is associated with inflammation. It is always associated with inflammation. Inflammation is always present. So if you ask me to describe the microscopic appearance, when I say microscopy, by default I mean light microscopy. If you ask me to explain the microscopic appearance of necrosis, first and foremost, it's going to look pink. Now, whenever we say something in pathology is pink, we mean it is eosinophilic. It is eosinophilic. Eosinophilic means eosin loving, pink loving. So it's pink in color. Number 2, it is going to be amorphous. What do I understand by amorphous? Now put a little bit of common sense into it. Morphous means morphology. Morphology would mean what? Morphology would mean size, shape, structure. But this is a cell death. Is a cell death going to have any size and shape and structure? No. So like I said, amorphous, no morphology. And the last thing that you see under the microscope is going to be, the definition had it, you will see inflammatory cells. Inflammation is present. So how does necrosis look under the microscope? Number 1, it is going to be pink. Second, it is amorphous. And third, it is going to have inflammation. Okay, so what are the types of necrosis? And no points for guessing. The most important thing that all of us have, the most common necrosis that we will start our journey with is the coagulative necrosis. Remember, I'm going to tell you 5 points about coagulative necrosis. If you know those, you are sorted. Let's begin. When I talk about coagulative necrosis, question number 1 is that it is the most common type of necrosis that we have. Question number 2 is they ask you, which is a previous year question, what is the mechanism of action? So think logically. Coagulative, coagulum. I want you to imagine everyone has boiled eggs in the kitchen once in a while in the hostel, yes? So what happens? Egg is liquidy, but when you boil it, when you heat it, what is happening? Does it coagulate? Does it solidify? That is coagulation. So why is an egg coagulating? Why does the egg become solid when you boil it? What is happening to its proteins? Somewhere there is a denaturation. So here also, why is this coagulative necrosis? Why is this coagulation happening? The mechanism of action is denaturation of the proteins. There is denaturation of proteins that is going to take place. Very important previous year question. Number 3 question, in which organs is it going to occur? So please remember, it occurs in the solid organs. It occurs in solid organs, and I'm going to give you some examples. So it occurs in the kidney, it occurs in the liver, it occurs in the heart, but most common question and most common clinical scenario that you shall get will be the heart. So they ask you again, another previous year question, which is the most common organ affected? And that is going to be the heart. So you will definitely get some heart attack history and you know you're dealing with coagulative necrosis. Okay, so I've not written all solid organs. No, I've not written the brain over here. Brain does not come. I've not written pancreas over here. They also don't come. So I'll tell you exceptions. For the time being, learn solid organs like kidney, liver and the heart. Okay, now coming to question number 4 and 5, which I will teach you directly from the images. So have a look at this, guys. Here I've given you a specimen of a kidney. Kidney is a solid organ, yes. And in that you can see this wedge-shaped structure. You can all see this wedge-shaped structure, and that is not necrosis. That is, initially if they ask you what is it, that is an infarct. What is an infarct? It is coagulative necrosis only. Definitely it is coagulative necrosis. But why are you calling it an infarct? Because somewhere the blood supply was going down. Why did this happen? So you'll ask me, why in the kidney is infarct happening? Why is coagulative necrosis happening? When the blood supply is going down, when the blood supply is being hampered, that is when an infarct is happening. That is where a coagulative necrosis is happening. And that's the classical shape. An infarct is usually in the kidney, it is a wedge-shaped structure. So that was question number 4, that you will get a gross image that will come from the kidney or any solid organ. Now comes question number 5, and how will it look like under the microscope? So this is another one of the few first pictures of pathology which are pink and blue that I'm teaching you. So remember, for this picture, we are going to divide it into two parts. We are going to divide it into two parts because this is the living part of the cell. Why do I say that? Very easy. Let's zoom into it. As you visualize, can you see inside every cell there's a blue color dot, means there's a nucleus. Over here, blue color dot. Every cell is having a blue color dot inside it. Nucleus is there. It's a living cell. Versus look at the other side of the picture. Do you notice over here, it's just a pink color outline. Over here also, it is just a pink color outline. Over here also, it is just a pink color outline. Do you see any nucleus inside it? No. This means this is not the living part. This means these are what? I'll draw them out for you. I am only seeing outline. You will say that the outline is preserved. The outline is preserved, but do you see any internal details? No, the details are lost. So is it looking like those typical ghosts that they show you in your Bollywood movies? Where how do they depict a ghost in a Bollywood movie? Someone wearing a white color sheet. So you can see that white outline, but you can't see the face and the body of the person, right? Same way. Outline is seen. Details are not seen. And that is exactly why these are known as ghost cells. So yes, what is question number 5? How does it look like under the microscope? It shows you ghost cells. Are you seeing one ghost cell? No. I can see so many. All of them are looking like ghosts. Have I entered into a graveyard? So many ghosts are seen. Have I entered into a graveyard? I think I have. So can I call this the very famous tombstone appearance? This is referred to as the very famous tombstone appearance. Because why tombstone? You've seen those stones that are present in the graveyard. So yeah, that is referred to as the tombstone appearance. Now having said that, your 5 questions of coagulative necrosis are done. But based on this, what did you analyze? There's one thing left. At the end of the day, we realized that kidney was a solid organ. Even if it has died, it is still a solid organ. There is no liquidy thing happening. Solid is remaining solid. Same way over here, even if the cells are dying, but their outline, remnants, outline is there. So can I all in all say that no matter what might have happened in coagulative necrosis, I'll tell you the most important question that they will ask you in the paper, and that is, tissue architecture shall remain preserved, because solid is remaining solid. The cells are still showing you an outline. So remember, the tissue architecture is going to be preserved. Well, having said that, that marks a wrap up to the first and the most common. Quick revision. The most common type is coagulative. The mechanism of action is denaturation. This occurs in solid organs. Which is the most common solid organ? You'll get a heart attack history, and that is the heart. Yes, tissue architecture is preserved. So what do I mean by that? That the kidney, which is solid, shall remain solid, showing you an infarct. The cells shall show you a full graveyard. You'll see lots of ghosts, and you'll see the tombstone appearance. So where else do you see the ghost cells and the tombstone appearance? Let's quickly revise that. So please remember, whenever ghost cell word will come in pathology, number 1, you will think of coagulative necrosis. That's point number 1. And the second that you're going to think of is a skin appendageal tumor, and that is pilomatrixoma. Pilomatrixoma. So if you ask me what kind of a tumor is it, oma means it's a benign tumor. Pilo word means hair. So it's a hair appendageal tumor. So remember, there are only 2 ghost cells of pathology that you have to know. Similarly, if someone asks you where else do you see the tombstone appearance? So reminding you that one tombstone is seen over here that you just studied, the coagulative necrosis, and there is a tombstone in dermatology or pathology, wherever you want to include it, and that is known as the row of tombstone appearance. So where in dermat or pathology do you see it? It is seen in pemphigus. And if I ask you a further question, which pemphigus? It is seen in pemphigus vulgaris, the row of tombstone appearance. Very, very important. So having said that, yes, 2 ghost cells and 2 tombstones, and this is why I taught you, because ghost cells and tombstones we were studying in coagulative necrosis. That wraps up the first necrosis that we have, coagulative necrosis. Now we move ahead and we study the second type, that is liquefactive. Now did you notice when I was teaching you coagulative necrosis, I said all the solid organs, but I did not mention the brain, And I did not mention the pancreas, because finally these two solid organs show you liquefactive necrosis. So what is the meaning? If I talk about liquefactive, something is going to become liquefied, right? So now when solid organ like brain is becoming liquid, can I basically say that the tissue architecture, look at this area, it's becoming a little liquidy. So do you think the tissue architecture is preserved? Not at all. So please remember that this is the difference between coagulative and liquefactive. The tissue architecture is not preserved. The tissue architecture is not going to be preserved. So let's take some examples. For example, you have like CNS, or I'm saying brain. For example, you have something to do with a stroke. So this is what is going to happen in the brain. For example, you have a case of pancreatitis. This is what is going to happen in the brain. So any reason, or if pancreatitis obviously going to happen in the pancreas. So any reason, guys, that why only brain and pancreas I'm considering over here? Because these are the enzymes which are very, very rich in enzymes. So these are very rich in hydrolytic enzymes. And that means that whenever enzymatic activity will be more, the area is going to become liquefied. So now examiner knows that you've learned all of this. This is basic. So he has started asking you, what is the other name of liquefactive necrosis? Colliquative necrosis. But it's so easy for me to analyze because the word liquid is coming everywhere, right? Whether I'm talking about liquefactive necrosis, the word liquid is coming over here. When I'm talking about colliquative necrosis, the word liquid is coming here. So I'll always analyze that, yeah, something liquid is happening either in the brain or the pancreas. And let me tell you one more example of this. Any abscess, because this is a common sense example. Abscess. What is an abscess? All of us have had an abscess also. Abscess, if I open an abscess, what comes out of it? Pus comes out of it. Pus is a liquid. So all infections and abscesses, they have pus in them. So that is also a kind of a liquefactive necrosis only. So now take home message. All the solid organs were coagulative necrosis. But which two organs are coming here? Liquefactive, the brain and the pancreas. Why? Because brain and pancreas have a lot of enzymes. That is why they are showing you liquefactive necrosis. Now coming to the third one. The third one is our country's favorite, and that is caseous necrosis. Living in India, you cannot ever forget this. So caseous necrosis is what? Firstly, look at this picture. What I see in this picture is the lungs. Now, why is this the lungs? Not because it looks like the shape of the lungs, but other than that, I can see these air spaces also inside it. So the reason for calling it the lungs is going to be the presence of air spaces. Now, having said that, this is showing me this appearance over here, which we call as the cheesy appearance. It's looking like cheese, like white like cheese, and that is the meaning of the word caseous. Caseous refers to cheesy appearance. So why is that happening? Please remember, caseous necrosis is a combination of coagulative necrosis and liquefactive necrosis. It's a combination of both. So if the examiner asks, caseous necrosis is coagulative or liquefactive or both, I would say both. But if the examiner says, no, pick up one of them, select the more common one. So remember, it is more commonly coagulative necrosis than liquefactive. But do you see how I have myself kind of contradicting myself? Because did I teach you any cheesiness in coagulative? No. Did I teach you any cheesiness in liquefactive? No. But when I'm combining the two, I have told you it has become cheesy. Any reason for that? Because now you must know the examples. And in our country, the most famous example, pulmonary tuberculosis or just tuberculosis of any site. One is tuberculosis. Other than that, this can also be seen in fungal infections. For example, a very famous fungal infection is histoplasmosis. Or you can also see it in coccidioidomycosis. Or other than that, we can also see this with cases of syphilis. Yes, they can also show us necrosis, caseous necrosis. So having said that, let's take up the example of everyone's favorite TB. Why is it that TB shows you caseous necrosis, or for that matter, fungus shows you caseous necrosis? Because remember, they have something that is present in their cell wall. They have a very high lipid content in their cell wall. They have a very high lipid content in the cell wall, as a result of which, see, lipid, cheese is always fatty, right? So why is this cheesy appearance coming? The cheesy appearance is coming because there is a lot of lipid, or there's a lot of fat that is present. All said and done, this is a very important picture, pulmonary tuberculosis in our country. You know, they're going to definitely ask you a question on cheesiness or caseous necrosis. What is the fourth necrosis that we have? And that is the famous fat necrosis. No points for guessing where is it going to occur. It's going to occur in all the fatty organs. So let me give you some examples again. When I talk about fat necrosis, example number one is breast. Breast is definitely going to have a lot of fat. Example number two that we have, omentum, the omentum around the GI organs, omentum in the abdomen, that also has a lot of fat. So we'll draw some yellow, I've written it in yellow so that we have a lot of yellow color fat in the breast. We have a lot of yellow color fat in the omentum. But here I'm not talking about fat, I'm talking about the breakdown of fat. I'm talking about fat being undergoing necrosis. So what do I notice? Imagine someone has had a trauma to the breast. How will someone have trauma to the breast? They'll give you a typical history. A typical previous year question will come on how the female was walking in the garden and there were kids who were playing football and football came and hit her on her chest. So that's a trauma. Next, someone has met with a road traffic accident. That's a trauma. Any kind of violence resulting in trauma. So whenever there is trauma, the fat cells will break down. There is definitely going to be a fat breakdown. And now I want all of you to recall from your school time. Whenever fat breaks down, what does it break down into? It breaks down into fatty acid, right? And is there a property? Remember in school, fatty acid always used to combine with what? Fatty acid used to combine with calcium. Remember saponification of fat. Fatty acid always used to combine with calcium. And what is the color of calcium? Calcium looks like a chalk. Everyone has seen. Calcium looks chalky white in color. So please remember that when we are talking about fat necrosis, it is to do with what? Number one, it's in the breast because breast is a fatty organ. Why will the fat break down? Because the female has met with the trauma. What will it break down into? It will break down into fatty acid. That fatty acid will attract what? Calcium, and calcium will look chalky white. Coming to the other example, that is omentum. So now omentum is around all the GI organs. Why do you think the omentum is going to break? So let's take an example of acute pancreatitis. Go back to your surgery and medicine and tell me that when there is acute pancreatitis, what is the enzyme that is released? Amylase is released, lipase is released. So can I say because of too much of lipase coming out, the same story is going to happen? The lipase will come and what will it do to the omentum? It's going to break the fat. So what is going to happen? The same journey, guys, the same journey of the fat breaking down is going to happen. The fat will break down into fatty acid will attract calcium and chalky white. So I realize the entire process is the same, only the organ and the reason is different. If it is occurring in the breast, then the reason is going to be trauma. And if it is occurring in the omentum, then the reason is going to be acute pancreatitis. Okay, so now let me show you a picture. Have a look at this. What I see over here, all this yellow color material, this is all the normal fat. But suddenly in the middle of this normal fat, I'm seeing these chalky white areas. I'm seeing the presence of chalky white areas. Why are they becoming so many more? You can see some tiny white areas more over here. Why are they becoming chalky white? Because they contain calcium, because calcium is present inside them, and that is because of fat necrosis, right? But now there's a question which students always ask me, because this creates a lot of confusion between them, and that is that when I'll get a question on pancreatitis, when I'll get a question on pancreatitis, am I going to mark liquefactive necrosis or fat necrosis? So listen to the question very carefully. Either they will ask you, what is the necrosis that is occurring within the pancreas? So within the pancreas, you will mark liquefactive necrosis. Why? Because see, within the pancreas, there is no fat. Inside the pancreas, it is liquefactive. But if they ask you that, okay, I am interested in knowing what is the kind of necrosis that is happening around the pancreas, because around the pancreas, there is fat. Around the pancreas, I can say there is peripancreatic fat. There is peripancreatic fat that is present. So what does that mean? So here I will mark fat necrosis. So whenever you get a question on pancreatitis, just read, where are they asking me for the necrosis? Are they asking for it within the pancreas? So that's liquefactive. Around the pancreas, that is fat necrosis. That wraps up fat necrosis for us. Let's move on to the next one, and that is going to be the fibrinoid necrosis. Now, whenever the word fibrin comes in front of me, the first thing coming to my mind should always be there is some antigen antibody reaction. And when I say antigen antibody, I mean some or the other immune complex is going to get deposited. Some or the other immune complex will get deposited. So let's repeat and let's think. Think of some infections or some diseases where this is going to happen. Antigen antibody. Do we all know there's a very important disease in the blood vessels called polyarteritis nodosa? For those who studied medicine and who've done systemic path also, you know we have done this. Polyarteritis nodosa, PAN. So this is definitely a blood vessel problem. Next, there's a disease in the heart, and what is that known as? That is referred to as rheumatic heart disease. Rheumatic heart disease because of streptococcus. What bodies are seen in rheumatic heart disease? The very famous bodies are the Aschoff bodies. Aschoff bodies are noted in rheumatic heart disease. Second, there's a disease called SLE. Similarly, there is also something known as malignant hypertension. So in all of these we will see fibrinoid necrosis. So repeating once again, guys, I realize all the three alphabet things have polyarteritis nodosa, rheumatic heart disease, SLE, HTN. All the three alphabet things are showing me fibrinoid necrosis. Having said that, let us have a look at the picture. See, first you need to identify what organ is this. So if you look very carefully, I can see a lumen. I can see a lumen over here, and in that lumen I see a lot of red blood cells. So that means this organ is a blood vessel. Yes, and if it's a blood vessel, what do you see around it? I see this pinkish color mass around it. You know, there's a band of pink color that is over here. This band of pink color is known as fibrinoid necrosis. This band of pink color is known as fibrinoid necrosis. So try to put 2 and 2 together. If it's a blood vessel and they have shown me fibrinoid necrosis, what disease can I think of? This is a disease of polyarteritis nodosa. As I said, this session is just not about going into just general path and that's it. It's about correlating it with medicine. How does a question of polyarteritis nodosa come to you? It is associated with hepatitis B. So they will always start a question. This image will be given and they will always start a question saying that there's a hepatitis B positive patient who has come to you with involvement of blood vessels of multiple organs. So that hepatitis B history is very important. Coming back regarding fibrinoid necrosis, all the three alphabet things, PAN, RHD, SLE and HTN, malignant hypertension. All of those show you fibrinoid. Now till here, what all have we studied? Coagulative, liquefactive, caseous, fat, fibrinoid. These 5 are my favorite. Why? Because they are a pathologist's diagnosis. Now, the 6th and the 7th that I'm going to tell you are not my favorite because they are the clinician's diagnosis. So, the 6th one that we have is gangrene. What do you understand by gangrene? Gangrene is the blackish discoloration. Gangrene is the blackish discoloration that we have of whichever organ you're talking about, and at the same time it is going to be very foul smelling. So it is black and foul smelling, and that is gangrene. And I think everyone is aware that gangrene is of 2 types. Some of them are, there are actually many types. 2 main types are dry gangrene and wet gangrene, right? So please remember, why did I say this is a clinician's diagnosis? I am not interested. Not that I'm not interested, but I don't do the terminology here. Why? Because blackish discoloration, the clinician will see in the patient. Foul smell, the clinician will smell in the patient. Finally, from the patient, what will be sent to me? The specimen will be surgically removed and sent to me. So when it is sent to me, for me, remember, dry gangrene is nothing but coagulative necrosis. And wet gangrene, wet means liquidy, so this is nothing but liquefactive necrosis. So like I said, is it anything new for the pathologist? Not really. Dry gangrene is the same as coagulative necrosis. Wet gangrene is the same as liquefactive necrosis. Now, there's another thing. Please remember, if I look at dry gangrene, which has happened in the foot, why is it dry? See, why is gangrene happening? Whether it is dry or whether it is wet, there is definitely a blood vessel occlusion or a blood vessel problem that has happened, right? So, if I see dry gangrene, I do see a proper line between the gangrene and the normal. So, I can say in dry gangrene, there is a line of demarcation that has been seen, line of demarcation present. Whereas look at wet gangrene. What is wet? This is also because the blood vessel has been occluded, but along with that there are infections. So dry gangrene is just the blood vessel getting occluded. Wet gangrene is blood vessel getting occluded plus there are infections that are also happening. That is what has made it infections, liquidy. That is why that liquefactive necrosis has come in, and therein I see no line of demarcation. There is no line of demarcation that I notice over here. I hope it is clear to everyone. Everyone's understood. A very quick recap. Gangrene is a clinician's term. Gangrene is not my term, right? Clinician says there's a foul smelling and there's a blackish discoloration that has happened. I am amputating the foot or whichever organ and I'm sending it to you. If it's dry gangrene, for me, what is it? Dry gangrene is coagulative necrosis. If it's wet gangrene, it is liquefactive necrosis. So it's a clinician's diagnosis. Okay, coming to the last necrosis that we have, which doesn't sound like a necrosis. Zenker's degeneration. 3 questions and you are sorted. Question number 1, Zenker's, so it doesn't have the word necrosis. First, let me fit in the word. It is again a type of coagulative necrosis. It has nothing to do with a new necrosis. It's the same coagulative necrosis. In which condition do you see it? We see it in typhoid fever, typhoid or enteric fever. So, now there comes the problem. Everyone has learned typhoid, salmonella, right? Typhoid means enteric. Enteric means intestine, food poisoning. Patient comes to you with food poisoning. Everyone believes that the necrosis is also happening. Food poisoning means intestine mein ho raha hai. No. This necrosis, please remember, is a complication. It's not seen in the intestine. It is seen in the muscles. It is very commonly seen in the skeletal muscles. They might ask you which are the different muscle groups in which you can see it. Please remember, this can be seen in rectus abdominis and this can be seen also in the diaphragmatic muscle. So remember, there is rectus abdominis and there is also diaphragmatic muscle. So now that is what wraps up Zenker's degeneration also for you. Firstly, although you call it a degeneration, but which kind of necrosis is it? It's a coagulative necrosis. In which infection do you see it? You see it in typhoid. And in which muscle is this necrosis seen? It is seen in the skeletal muscles. Yes, with that, we wrap up our discussion of the initial part, and that is the first cell death, that is necrosis. Now, having said that, let us go ahead and practice a few questions with regard to not only the necrosis but also the reversible and the irreversible cell injury. So, it's time for a test in between. So, first and foremost, where do you see myelin figures? What are myelin figures derived from? So, myelin figures are what? Myelin figures were made up of what, guys? They were made up of phospholipids and calcium. So, where should a phospholipid come from? Phospholipid is going to come from the cell membrane. That is a previous year question. Let's move on to the next question, a lengthy one. Here you have a 61-year-old female patient who presents with left-sided chest pain radiating to the left arm and the jaw. It's quite a classical history of MI. Patient explains that the pain has increased severely over the past 40 minutes. She is immediately rushed to the hospital. Cardiac enzymes are elevated, again telling you it's MI. Patient is admitted, started on thrombolytic therapy. However, on the 5th day of observation, she collapses and dies. So you have ultimately had a patient who has succumbed to the illness, has died. Which of the following necrosis would you most likely expect? So that is how the questions would be integrated. Please remember, it starts off as a typical medicine question. It ends as a pathology question. Which subject would you put it in? Both, right? So what is the necrosis that you see in the heart? And we know heart is a solid organ. And whenever any solid organ is put up in front of me, my answer is going to be coagulative necrosis, right? Let's take up another question. You have a 45-year-old female patient who complains of being hit on the chest by a football while passing through the garden 4 weeks back. So it's quite an old history. It's a 1-month-old history. But yeah, there is a history of trauma definitely that is there 4 weeks ago. right? Next, what do I say? So as soon as she got hit, initially they are saying, initially the left breast was tender and swollen, obviously because of trauma. But after that, we realized the tenderness has subsided. However, now she is saying that I am seeing a lump in the periareolar region, and that lump is firm to hard in consistency. Now, don't be biased. When a 45-year-old female comes to me with a lump and that lump in the consistency is firm to hard, cancer will always come to my mind. Let's not be biased with necrosis. Should I have actually thought of breast cancer? Yes, I should have. Radiology showed you calcium deposits. Does radiology show you calcium deposits in cancer? Yes. I should not have ruled out cancer. Cancer should have been in my mind. But as soon as she told me that this all has happened after a trauma which happened 4 weeks ago, and the options that I see below are all necrosis, that is when I say, okay, the examiner doesn't want me to go towards cancer. The examiner wants me to go towards a necrosis, and in the breast following trauma, of course, it is fat necrosis. Having said that, we wrap up our discussion of the reversible cell injury, irreversible cell injury, and the first cell death, that is necrosis. Now we'll move forward and we'll discuss the next cell death, and that is apoptosis. The next cell death that we start with is going to be apoptosis. Now, yes, this is another very, very important topic that we have in pathology, which is never aging, which means that it's always going to get you questions. It's an evergreen cell death. And let's start right away. Well, guys, if you've read necrosis, this means that I now have the liberty of telling you differences between necrosis and apoptosis as well, right? So let us start with the first thing, and that is apoptosis definition. So if you all remember, compare it with necrosis. Necrosis was what? It was only pathological. Apoptosis is going to be both. It is going to be both physiological as well as pathological. That means it can occur in normal people also, and it can occur in cases of diseases as well. It is both physiological as well as pathological. Coming to the next, what is the definition? I think everyone knows that apoptosis is known as programmed cell death. Now, even, this is, I always tell students in offline classes also that there'll be a day when you'll finish off all these exams, NEET, FMG, INI, or NEXT, or whichever exam, and everything will finish. And, you'll start forgetting all this information eventually. But one thing that you will even remember at the age of 60, 65, when you're nearing your retirement, is this definition, because no one ever who has entered MBBS has forgotten this. This is that kind of a definition, that apoptosis is a programmed cell death. So examiner thought that let me change the definition. Now this has been updated. It is known as caspase dependent programmed cell death. It is said to be caspase dependent programmed cell death. I'll tell you what is the meaning of caspase in a while, but yes. But do you also know what is the meaning of the word apoptosis? It actually comes from a Greek word, and the meaning of the word apoptosis is falling off. Apoptosis means falling off. And why is it called falling off? I'll need 15 to 20 minutes and I'll get you back to this slide and prove that yes, why is it called falling off? Okay, does it need ATP usage? Correct. Remember AAA. When you're talking about apoptosis, does it require ATP usage? Yes, it is going to use ATP. So another A. And that is why this is known as an active process, another A. So apoptosis is an active process. Why? Why do you call it active? Because it uses ATP. Now, well, having said that, please remember, when the ATP will not be used, where do you think that is going to happen? In necrosis, did I mention anything about ATP? Of course not. Nothing about ATP. So do you want to call it active? Again, no, I want to call it a passive process. Necrosis is going to be a passive process because ATP is not used. In apoptosis, ATP is used. Okay, talking about inflammation, again compare, did necrosis have inflammation? Yes. Will apoptosis have inflammation? And it's a big no. And why is that no? That also I'll explain in a while. All of this will come in the pathophysiology and the mechanism. Okay, now coming back to where I started from. Is it physiological or pathological or both? As I can see, it is both. So let us study some examples. When is it said to be physiological? And the most famous example is organogenesis, when the organ formation is happening in the body. Guys, which system or which time of the life does that happen? At the time of the embryo. So that is embryogenesis. Organogenesis or embryogenesis is the time in life where, physiological, normal. Can I give you some example, a very famous example? See, when you've thought, how is your hand formed? So if we talk about this as the hand and we have like these 5 separate fingers, but always we did not have these 5 separate fingers. Initially our hand was like this, one mass of tissue, right? It was one mass of tissue like this. Gradually your 5 fingers formed and gradually there was a space created between them. So where did the tissue go? Where did the tissue go eventually? In between the fingers. Where has it vanished? It has vanished by apoptosis. And is that normal? Of course, all this tissue, that is how the finger webs were formed. So one very important example is hand formation, or you can talk about finger formation. And let's talk about a disease, integration time. What if the fingers were like this and apoptosis did not happen? Would I or everyone would have been born with what? Fused fingers. Can I say if this process undergoes a defect, patient will have fused fingers, and that is known as syndactyly. That is going to be syndactyly. So all the fingers are going to be fused. That's a clinical implication. Okay, other than that, let's look at some day-to-day examples. I think everyone knows the next chapter that you study in pathology is inflammation. And in everyone knows that in inflammation, one very important cell is the neutrophils, right? So whenever inflammation will happen, neutrophils will come. But when inflammation is over, neutrophils have to go back also, right? They can't stay there forever. So how is the neutrophil clearance going to happen later on? The neutrophil clearance will happen by apoptosis. So that is also normal. When my body needs inflammation, neutrophils are coming. When my body does not need inflammation, neutrophils are going away. Okay, any other example in female especially? So what happens during menstruation? There is endometrial shedding. Endometrial shedding happens in menstruation, right? So that is also an example that you have for physiological. So basic concept is everything that is happening normally. This means apoptosis can occur normally. Now I'm going to go ahead and tell you a pathological example, and some very famous bodies are coming up your way. And what is that body? The famous Councilman bodies. First and foremost, where do you see Councilman bodies? Councilman bodies are seen in a case of viral hepatitis, and most commonly which viral hepatitis? Hepatitis C virus. So there's a very simple way of learning it. We have C for Councilman bodies and C for hepatitis C virus. So Councilman bodies are seen with hepatitis C, and what are they? They are a kind of apoptosis. That's why I'm making you study over here. Are there any other C bodies that you see in dermatology also? They are known as civet or colloid or cytoid bodies, and other lots of C's. Civet or colloid or cytoid bodies. In which disease of dermatology do you see it? We see it with lichen planus. And now when you go and study lichen planus, you will realize that yes, this is a question. This is a question that we get, that lichen planus shows you civet bodies and they are a type of apoptosis. So the two C bodies are coming up your way, right? Both of them are apoptosis. Now I'm going to tell you something very, very classical, which you've heard of. In day-to-day life, you've heard of. Now you're going to think of it from this point of view. So what happens when a patient is suffering with cancer? What do we do? So whenever a patient is suffering with cancer, we are going to give chemotherapy, right? We give chemotherapy. What does chemotherapy do? Chemotherapy is going to go and cause cancer cell death. Have you ever wondered how is the cancer cell death happening? Is it happening because of necrosis? Is it happening because of apoptosis? So please remember, cancer cell death is happening because of both apoptosis as well as necrosis, but it's an 80-20 scenario. Means much more common mechanism is apoptosis, and a very lesser, you don't have to learn the percentages, I'm only telling you for your knowledge, that a much more common mechanism for killing the cancer cells is the apoptosis, and a lesser important is the necrosis. I hope everyone's okay with this. Taking you back, so what part of definition have we covered? The first part where I told you it is physiological and pathological, done. The next part of the definition is it is a type of a programmed cell death, and that too caspase dependent. So now I need to teach you what is caspase. That's the next part of the story. So please remember, we are going to split caspase. How do you write caspase from today onwards? This is how I will expect you to write. This is how I will expect you to write caspase. What does that mean? Ase basically means enzymes. Ase is going to mean, like we say lipase, protease. Ase always means an enzyme. So yeah, this is enzyme activity. If I give you one molecule, for example, if this pencil is a caspase, I ask you, what is this pencil made up of? So if I ask you, what is this caspase made up of? You'll say there's a tiny little portion over here, and that is C. It is made up of something called C. So what is C? The C in caspase stands for cysteine residues. The C in caspase is going to stand for cysteine residues. So please remember, what does caspase contain? Cysteine residues. Next, what does an enzyme do? Every enzyme has to break something. So for example, this is a molecule, any random molecule of the body I have drawn over here. You want to break this. Caspase says, I want to break it, break it, break it. How should I break it? It can't just go and break it anywhere. Please remember, wherever it will see aspartic acid, it will break it. The next time it sees aspartic acid, it will break it. Next time it will see aspartic acid, it will break it. So can I say the ASP means that caspase will break after aspartic acid residues. Whenever it will see aspartic acid residues, it is going to go and break that molecule. So simple, you've done all the three alphabets. What is C standing for? It contains cysteine. What is ASP standing for? It contains it is going to break after aspartic acid residues. And what is ASE? It's an enzyme. Now, having said that, there are many types of caspases. Numbers are going to come your way. So it's now time that we go ahead and study the mechanism of apoptosis. Now, when I talk about the mechanism of apoptosis, please remember, learn it like a story that I am telling you, because it will make life a little easier. When I'm talking about apoptosis, it can have initiation and it can have execution. So now let me ask you, whenever you guys decide that you have to study, and all of us, when do we decide to study? Either we decide to study from the Monday of every week, or we decide to study from the first of every month. So what do you do? So once you know that, okay, now tomorrow is first, I have to study from first. So what will you do today? Today you will sit down, you will make a timetable, you will call your friends, you will ask which app is better, which notes are better, from where should I get the PDFs, notes, all of that, things you'll start accumulating, because you know that tomorrow is first and tomorrow I have to execute my plan. So the first part of your entire plan is going to be initiation. You'll make a timetable, buy some app, get some notes, get some PDFs, join some Telegram groups. All that is preparation time. So that is initiation. Why? Because tomorrow you have to study. Tomorrow is first. Tomorrow is your execution. And the chances are that if you are listening to this lecture today might be the first. That is why you're listening to the first chapter of pathology. But jokes apart, apoptosis is just like all of us. It has an initiation and it has an execution. Having said that, please remember, what is tougher? Initiation is always tougher, because you have to call your friends and ask which app are you studying from, and also you have to get over the fear of missing out. FOMO is a big disease now that I call, which all of us are suffering from. So you don't want that. You should not have the app which your friend has. All of you should have everything that your friends and your peers are studying from. So initiation is always difficult, and also getting that motivation to study, that is the most difficult part to get, right? So how do I go ahead and decide on this? So to start something is very difficult. Same way, to start the apoptosis, there are two pathways. The pathway happening outside the cell, extrinsic, and the pathway happening inside the cell, that is intrinsic. I'll give you your example. Initiation, you want to start your studies. Why will you start? Because outside, someone from outside is constantly scolding you. Your parents are constantly scolding you that you have to study and when will you clear this exam. So that is outside motivation. Then there is also an element of guilt inside you that, I haven't studied since a week. It's high time that I start studying. I wasted too much of time in watching social media reels. So there is an inside motivation also. Same for apoptosis. There's an outside motivation and there's an inside motivation. So let's start one by one. Once the initiation part will be done, automatically your body will take you towards the execution. And do you know what do I need for all of these? I need caspases. Remember, I just taught you it is caspase dependent programmed cell death. So yes, I need a lot of caspases. So what is that going to be? So please remember, for initiation, we have caspase 8, 9 and 10. For initiation, we have caspase 8, 9 and 10. For execution, we have caspase 3, 6 and 7. And how am I going to learn it? Now listen further. For initiation, 8, 9 and 10 is in order. Out of them, in extrinsic pathway, we have caspase 8 and 10. And in intrinsic pathway, we have caspase 9. How do we learn it? See, the way you write extrinsic, the way you're going to write extrinsic, how do you write it? E and X. So E will remind you of 8 and X looks like a 10. So 8 and 10. Remember, extrinsic pathway is going to activate which caspase? That is what I've written. It is going to activate 8 and 10. Whereas what is left for intrinsic pathway? For intrinsic pathway, we have caspase 9 that is left, right? So 8, 9, 10 has been completed. Yes. Now we go on to the execution. In execution, we have 3, 6 and 7. But if there's a question that which is the most important caspase out of all of these, remember the first number out of all of these, the youngest number, caspase 3. Caspase 3 is the most important caspase that we have. You've learned the entire story of caspases. Now I'm going to go into the details. We will start with apoptosis mechanism. I'm starting with initiation. Under initiation, I'm starting with the extrinsic pathway. So let's begin. When I talk about the extrinsic pathway, please remember that something is going to happen where? Outside the cells. So let me draw a cell over here. This is a cell which is the cell which is wanting to die. So can I in other words say this is the apoptotic cell. On the other hand, I am drawing another cell over here. Which cell of my body? I am drawing the T cells of my body. The immunity cells, the T cells. Why am I drawing these? Now listen. The cell which wants to die, it has something on its surface which is referred to as CD95 or FAS. Every cell that wants to die has CD95 or FAS. So now, corresponding to that, on the T cells, there is something called CD95 ligand or FAS ligand. So there's one receptor, there's a ligand. Obviously, the cell which wants to die has CD95. So for example, this is the cell which wants to die. This has CD95. So this is a T cell that I've given, which is going to have a ligand. So that 95 and 95 ligand can bind. As simple as that. Okay, but this is just one-on-one interaction. You tell me, if this cell, this apoptotic cell is you wanting to study, so how are you getting your motivation? From outside. These T cells are your parents who are constantly scolding you that padho, do something in life, study. But do you think one time they scold you and you're going to listen? No. You need 2-3 times repeated scolding. So after they scold you repeated times, what do you say? You'll say, okay, I can't study alone. Let me make a study group. And that is what most of the messages that I come across on social media platforms is looking for a study partner, kindly DM and all of those. So you start looking for a study partner. Similarly, CD95 says, I can't do this process alone. Give me 2 more CD95s. So what has happened? Can I say there is trimerization of CD95 that has happened? There is trimerization of CD95 that has taken place, or you can also call it FAS, right? Okay, having said that, now 3 of you have become a group and you decide that we are going to study. But have you ever studied? 3 of you sitting in the hostel room, if 3 people get together, it's always a party or a movie time. It's never study time. But yeah, so you decided that, okay, we'll study. 3 of you got together. What did you do? When you couldn't study, you decided, okay, let us message ma'am and ask her that how should we study? We are trying, or let me ask some senior. So now you say that after these 3 people get together, let us now call some senior, and that senior is known as FAD. The senior or the teacher who's finally going to help you. What is FAD? FAD is known as FAS Associated Death Domain. The senior or the teacher who's finally going to make you all study FAS Associated Death Domain. And you know what this FAD will do? This will now activate the caspases. Which caspases? Reminding you once again, when I say extrinsic pathway, which caspases? There is 8 and there is 10. So can I say this will activate? This will activate procaspase 8 and 10 into caspase 8 and 10. That is how the activation will occur. So you wanted to do that. You wanted to activate these 2 caspases and your pathway has been finished, right? But remember, finally you called your senior. Who's your senior? Your senior is FAD. So probably I am your senior. Okay, so I am FAS Associated Death Domain. I have taught you pathology and I have completed your syllabus. But will there always be someone in your hostel who will say, don't study, kuch nahi rakha, there's nothing left in studies, just let's go out and chill. So there will always be someone who will be stopping you from listening to my lectures. And who is that someone? That someone is Flip. So now tell me, Flip, inhibits this entire process. So the question that you get in the paper, answer this question first. When you're talking about this question, they ask you, what is PHLIP? Is PHLIP a pro-apoptotic molecule or an anti-apoptotic molecule? So I hope all of you have gathered up till now that PHLIP is going to be an anti-apoptotic molecule. PHLIP is going to be an anti-apoptotic molecule, and it is an anti-apoptotic molecule for which pathway? It is for the extrinsic pathway. Very famous PYQ that you have, which you must know. So coming back, that marks the end of the extrinsic pathway. Because I was talking so much about FAD, fast associated death domain, can I call it the death receptor pathway? Because everything that I'm talking about is FAS and FAD. So this is the death receptor pathway. Yes, one pathway is done. Someone's scolding you from outside, extrinsic. Whatever was happening from outside the cells. What am I going to get back to? So your extrinsic pathway is done. Caspase 8 and 10 have been activated. Now we move on to the intrinsic pathway to activate caspase 9. So starting with the intrinsic pathway for the initiation, and like I said, something is going to begin from within the cell, inside the cell. So that means I'm going to draw a cell over here. This is the cell which has to undergo apoptosis. But why are you wanting to making it undergo apoptosis? Because it has undergone some kind of stress. And when I say stress, let's consider a stress, for example, ultraviolet light. Okay, ultraviolet light comes onto our skin cells. Obviously, we get under a lot of stress. You know who detects that stress? We have a few stress sensors in our body. We have a few stress sensors in our body, and let's learn it like a rhyme. These include BIM, BID, BAD, NOXA and PUMA. So like I said, there's a kind of a rhyme or a sound to it, a song to it. BIM, BID, BAD, NOXA and PUMA. These are said to be stress sensors. As soon as little bit of stress comes, some hormonal stress, some nutrition stress, ultraviolet stress, poison, chemical, any kind of stress comes, and they start ringing like alarms. They start ringing that, okay, some problem is going on in the body. So what is going to happen because of that? Now these stress sensors then say that, okay, you tell me yourself, do you like any stressful situation in your life? Of course not. So when they find out that this cell has undergone a stress, they say, get rid of this cell. What do they say? They will say, increase the pro-apoptotic factors. Increase the pro-apoptotic factors and decrease the anti-apoptotic factors. That is what they are going to say. They say increase. So see, normally what happens? Pro and anti. Everything is equal in your body. Pro-apoptotic factors and anti-apoptotic factors are equal. So they say, I want apoptosis to occur. Increase the pro-apoptotic factors and decrease the anti-apoptotic factors. That is exactly what is going to happen. So you're moving closer to apoptosis. So now you will ask me, what are the pro and the anti-apoptotic factors? One of the most famous previous year questions that you have. So yes, what are the pro-apoptotic factors and what are the anti-apoptotic factors? So first let's make a list. P53, BAX, BCLXS. So remember, P53, BAX, BCLXS, these are pro-apoptotic. Whereas when I say BCL2, MCL1 and BCLXL, these are anti-apoptotic. How should we learn this? As simple as that. So see, when I say anti-apoptotic, you are trying to lower apoptosis, right? So all the L containing molecules, let's highlight. We have BCL2, we have MCL1, and which BCL? Am I talking about XS or XL? XL. So remember all the L molecules, BCL2, MCL1, BCLXL, all of these are going to be L for lowering apoptosis, means they are all anti-apoptotic. L wala molecules are anti-apoptotic. Sounds well? Anything other than that? So P53, then BAC, then BAX, then BCLXS. They are not XL, XS. They are all increasing apoptosis. So now there is also one more previous year question. If they ask you, where would you place the BCL family? Do you want to call it pro or anti or both? I would want to call it both. Why so? Because I can see the BCL member over here also, and I can see the BCL members over here also. So I would say, if as a family I am asked, they are going to be both pro and anti-apoptotic. Coming back to why I was reading it, have a look at it, guys. What has happened in your body? There has been some element of stress, like an ultraviolet stress. Your alarm clock started ringing. Bim bit bad, noxa puma. They started ringing. They said increase the pro-apoptotic factors and decrease the anti-apoptotic factors. You want to move towards apoptosis now. How should I carry it out? Please remember that now it's the time that you're going to go and give a signal to the favorite organelle of your body. Which is the favorite organelle of this entire chapter also? These say that, okay, pro-apoptotic factors have increased. They say we are going to go and give a signal to the mitochondria. So now comes the next question. Let me draw the mitochondria and finish off this entire intrinsic pathway. So the mitochondria is the hero of the story. We say, who plays a pivotal role in apoptosis? Pivotal role means main role. Hero wala role. So who plays the pivotal role of apoptosis? And that is mitochondria. And what role does it play? Listen to me. Mitochondria has two molecules which is going to be released. One molecule is known as cytochrome C, and the other molecule is known as SMAC and Diablo. And the other one is known as SMAC and Diablo. So having said that, please remember, cytochrome C that has come out is going to combine with a molecule called APAF1. If you are one of those who like to know full forms, APAF stands for apoptosis activating factor 1. Apoptosis activating factor. So AP and AF, apoptosis activating factor 1. So APAF1 is what it combines with, and together these two things are known as apoptosome. So many of the books also describe that apoptosome, there's, they tell you about the structure of apoptosome. They say it looks like a wheel-like hexamer. So there are some books calling it a hexamer, some books are also calling it a heptamer. I don't want you to get into that controversy because such kind of factual questions are becoming very, very rare nowadays. But yeah, wheel-like hexamer is mentioned in many of the books. So what is the main function? Why have I made? So first previous year question that comes is, what is an apoptosome made up of? Do you know the two things? It is made up of cytochrome C and APAF1. The next question that comes is, why have you made it? Because what was the caspase that you were wanting to activate? Intrinsic pathway, guys. Which caspase? Pro-caspase 9 had to be activated into caspase 9, and that is exactly what we are doing. So have we accomplished our mission? We wanted to activate caspase 9 in the intrinsic pathway, and we have done that. And who played the pivotal role? That was by mitochondria. So can I now say that the other name for the intrinsic pathway is the mitochondrial pathway, because it's the mitochondria which has actually done all the work. So going all the way back, how many pathways did you have? You were supposed to study the extrinsic pathway where you did all the FAS, FAD and death receptor things. The intrinsic pathway is also done where you've spoken all about the mitochondria. So the mitochondrial pathway is also over. Okay, having said that, why did you do? So like I told you, starting off your timetable is always difficult, right? Now you've done that initiation, you've done 8, 9, 10. Why have you done that? Because you wanted to go all the way up till execution, and that is what I'm going to start with next. So ultimately, I realize that we have started off with something known as 8, 9 and 10. What were these? These were caspases 8, 9 and 10, and because of this now I have entered. So what was this? This was all initiation, but now I have entered into the next step, and that is activation of caspase 3, 6 and 7. So it's a chain reaction. It's a chain reaction. When 8, 9 and 10 will get activated, automatically they will go and activate 3, 6 and 7. This means automatically I have entered into the process of execution. So is the story over? No. Can caspase just go and kill the cell? Not at all. These will then activate some enzymes in the body. And which enzymes are we talking about? So please remember, these enzymes are the 3 backbones. Do you remember the 3 backbones of your cell? Phospholipid, protein and nucleus. So which enzyme will you activate? First one, for phospholipids you will activate phospholipase. For proteins, you will activate protease, and for nucleus you will activate nuclease, but with a twist in the story, because here what I activate is an endonuclease. So please remember that whenever you want to break the cell, target three things, three backbones of the cell: phospholipids, proteins, nucleus. So phospholipase, protease, nuclease. Now always I get stuck on this story of nuclease, right? What is the difference between a nuclease and an endonuclease? That I have to explain to you. So what I'll do, guys, I'll draw one nucleus for you. When I say I'll draw one nucleus for you, I am going to basically draw the DNA. In simple words, I have drawn the DNA over here. Now this enzyme has to go and break the DNA. Can it break the DNA just like that? Just go and break it anywhere? No. Why am I calling it endonuclease? What is its special property? It says I will break at regular intervals. I am going to break at regular intervals. At what intervals? Please remember, it breaks after 180 to 200 base pairs. 180 to 200 base pairs means as soon as 180 base pairs are done, it will break. After another 180 base pairs, break. After another 180, break. So it follows a rule in life. It has a principle in life. 180, break. 180, break. That is how an endonuclease works. And this very, very simple step, 180 break, 180 break. How simple is it? But they have given it a very, very fancy name. And this process is referred to as the very famous internucleosomal cleavage. Like I said, that it's such a simple thing, but such a fancy name. Internucleosomal cleavage. So now if I ask you, what is internucleosomal cleavage, or which enzyme is responsible for internucleosomal cleavage? It is the endonuclease. After how many base pairs does an endonuclease act? After every 180 to 200. So 180 you can learn. So it's 180 cut, 180 cut, 180 cut. That is how. So is it cutting in packets of 180, then 180, then 180? You know, in a while I'll tell you something called step ladder pattern. And if I ask you what is the reason of step ladder pattern, this is going to be the reason. So give me another 5 minutes and we'll apply this knowledge. So I have ultimately realized that to break a cell, first I did initiation, caspase 8, 9, 10. Then I did execution, caspase 3, 6, 7. They activated further enzymes. 3 enzymes: phospholipase, protease, nuclease. The nuclease is a little bit of a VVIP nuclease. It's an endonuclease, which is going to carry out internucleosomal cleavage. So now your question is, finally has the cell broken off? No, because now I'm going to draw that big cell, guys. This was the cell which I wanted should undergo apoptosis. This was the cell. This was the nucleus of the cell, and I'll draw a few random organelles. I'll draw the endoplasmic reticulum. I'll draw some ribosomes, lysosomes. I'll draw a little bit of mitochondria. This is the cell which had to undergo apoptosis. Now let me see how many of you remember the first sentence of apoptosis. Apoptosis is what? It comes from a Greek word. What is the meaning of that Greek word? Apoptosis means falling off, and I told you that I'll tell you in the next 15-20 minutes what is falling off. So do you think the initiation happened, the execution happened, and this cell has broken off? No. It doesn't break off like this within a second. It breaks off in bits and pieces. Means little bit of part fell off, then another little bit of part fell off, then another little bit of part fell off. I've drawn them very strategically. Don't think I'm just making random lines. In the first cycle, endoplasmic reticulum fell off. In the second cycle, mitochondria and little bit of nucleus. In the third cycle, only and only nucleus. So what is it going to fall off into? It's going to fall off into tiny, tiny bodies known as apoptotic bodies. So they ask you, what is the definition of apoptotic bodies? Do the apoptotic bodies have a nucleus or they don't? Both possibilities are there. What are apoptotic bodies? They are cell membrane bound organelles. They are cell membrane bound organelles with or without the nucleus. With or without the nucleus means sometimes the nucleus will fall off, sometimes the nucleus will not fall off, sometimes the mitochondria will fall off, sometimes it will not fall off. So all possibilities are there, and that is the definition of an apoptotic body. So don't you feel you've created more of a chaos? You started off with one cell which had to die, and you have actually converted it into thousands of tiny, tiny, tiny bodies. You wanted to die, you want to get rid of it. How should you get rid of it? Is there any one cell in your body which is all-time hungry, forever hungry? You give it food and it's like just all of us. You give it some nice delicious food and it will say, okay, I have space in my tummy and I'll eat it. What is that cell? It's a macrophage. So now these apoptotic bodies are going to send an eat me signal. They send an eat me signal to the macrophage and tell the macrophage that please come and eat us and carry out phagocytosis. That is when apoptosis is going to be complete. All these tiny bodies, they will actually call the macrophage that, okay, please come and eat us because it's time for us to go away from the body. And macrophage finally carries out phagocytosis. So now for students who are preparing for higher exams, please remember they will also ask you a question on what is this eat me signal. So now I'll tell you a latest update, and this is the Robbins 10th edition update that all of you have to know, and that is a process known as efferocytosis. So listen to me very carefully. So what is efferocytosis? Now right now what did I tell you? That there are these tiny bodies, right? Tiny bodies. And what signal are they giving to the macrophage? So let's go ahead. What signal are they going to give to the macrophage? That signal is going to be eat me signal. So have you ever wondered what is this eat me signal that is going to go to the macrophage? So what are these eat me signals that these apoptotic bodies are going to express? They start expressing something known as C1q. Next, they can express something known as thrombospondin. The next one is going to be PS. Now this is the most important. What is PS? PS is known as phosphatidylserine, and I want all of you to go back to your biochemistry now. Normally tell me, forget all this apoptosis for a minute. Tell me. Phosphatidylserine, where is it present in your normal cells of the body? Let me draw a normal cell in the body, and any normal cell has how many phospholipid monolayer or bilayer? Every normal cell has a phospholipid bilayer, right? So I have drawn a phospholipid bilayer. Now in a normal cell, tell me, where is phosphatidylserine present? Always on the inner leaflet. Phosphatidylserine is always present on the inner leaflet, but that is the situation of a normal cell. Do you know what is going to happen when I'm talking about an apoptotic cell? This phosphatidylserine tends to come out. It tends to come out. So can I say there is flipping of phosphatidylserine that happens in apoptosis? Very important. Phosphatidylserine flipping will happen in the apoptotic bodies, and that is a signal. That is how the macrophage gets to know that, oh, the phosphatidylserine has come out. It's time for me to go and eat it. Till the time the phosphatidylserine was inside, it was a normal situation. Now the phosphatidylserine has gone out, means the macrophage says, okay, now it's time for me to go and eat it. That is why I'm calling them eat me signals. C1q, thrombospondin and phosphatidylserine, these are eat me signals. As soon as they will flip and come out, the macrophage will know that it's time for me to eat the cells. And this process where macrophage is going to go and engulf it, that process is referred to as efferocytosis. That process is known as efferocytosis. In fact, let me tell you guys that nowadays, another update that I'm telling you, that nowadays, that if there is a defect in efferocytosis, or if there is a defect in efferosome or efferocytosis, there are a lot of diseases that have come up, particularly a lot of lung and autoimmune diseases like SLE. In the lungs, they are saying this is associated with COPD. This is associated with bronchiectasis, and this is also associated with conditions like cystic fibrosis. Yes, so having said that, these are all under, research and development that is at present, but this is one of the hot favorite new topics that we have, efferocytosis. If I have to put it up in simple words, please remember, we had from one big cell, we had tiny little cells or apoptotic bodies that had formed. They sent an eat me signal, and which is the most important eat me signal? It is phosphatidylserine flipping that happened, and that is going to send a signal to the macrophage that come and eat me and eliminate me. That is what happens, and finally the apoptosis is done. One last question which is important for students appearing for INI-CET exam. Like I told you, defect in efferocytosis can cause diseases. There is also a defect in the phosphatidylserine flipping. And do you know what is that disease? Very famous disease that you have also in hematology, which you will and we will also study in hematology. If there's a defect in phosphatidylserine flipping, that is known as the Scott syndrome. Scott syndrome. So like I said, number one, Scott syndrome, if see PS flipping will not occur, this means apoptosis is not going to be complete. This means there's going to be an apoptosis defect. Similarly, in hematology, this is a very important platelet step also that should take place. PS flipping is very important for the clotting pathway and platelets, for the blood clot formation. So if the PS flipping will not take place, the blood clotting formation is also going to suffer. So I will be talking about the PS flipping once again when we go to the platelet chapter. Okay, all said and done. We are coming back. One more thing for INICET students. Have you ever wondered that when every cell is showing me signals, eat me signals that come and eat me, why don't cancer cells also show you those signals? And then why don't macrophages eat the cancer cells also? Because cancer cells are very smart. Do cancer cells want to be eaten up by your body? No. Cancer cells will start showing you a do not eat me signal. That is what is very interesting about a cancer cell. So please remember that while all the cells show you eat me signals, if I draw something like a cancer cell, if I say this is a cancer cell, this is going to start expressing something called CD47, and I have called CD47 as a do not eat me signal. It is a do not eat me signal, which basically means that cancer cell will say that I am showing CD47, and macrophage will say, okay, if I am seeing CD47, I am not going to eat it. That is how cancer cell survival occurs. Cancer cell survives by giving signals of threatening us that I am showing CD47, do not eat me. So it's a do not eat me signal. All said and done, finally apoptosis comes to an end. But before we end it, there are certain Robbins 10th edition updates that you have to know. This is only important from RATA or rote learning point of view. It is not at all any concept or clinical integration, but yeah, it's an update and it's important. So please remember, they have come across with the structure. They analyzed a lot of structural details, and they came across with the structures that are important for the the different molecules that we have studied up till now. So they said that first molecule that you had were the stress sensors. Stress sensors were what? Remember that rhyme? Bim bit bad knocks up Yuma, right? So bim bit bad knocks up Yuma, that rhyme. So please remember, stress sensors have how many BH domains? BH is actually BCL homologues. I don't want you to learn so much of information. I just want you to learn that there are some structures in it. Remember, the way you write stress sounds like tree or 3. Stress sounds like 3. So how many BH domains is it going to have? It is only going to have BH3. So 3 and should remind you of 3, right? So stress sensors, bim bit bad knocks up Yuma, they have only BH3. Talking about pro-apoptotic molecules and anti-apoptotic molecules. Do you remember pro and anti? All the LLL ones were anti and others were pro. Yes? How many alphabets does pro have? 1, 2, 3. How many alphabets does anti have? 1, 2, 3, 4. So that's the structure. How many BH domains will pro have? Ranging from 1 to 3, because pro is 1 PRO, 1, 2, 3 alphabets. So for 3 alphabets, we will say it can have anywhere between 1 to 3 kind of domains, and anti has 4 alphabets. When it has 4 alphabets, how many BH domains can it have? It can have BH 1, 2, 3, 4. That's the easiest way that I could think of how I learned it. So pro molecules have 1, 2, 3, anti-molecules have 1, 2, 3, 4, and stress sensors have 3, so they are going to have 3 only. Only the BH3 molecule is present. Another update that requires a little bit of your concern. There is an update that has come regarding SMAC and Diablo. There is an update regarding SMAC and Diablo. And what is that update? Do you remember first? Where was SMAC and Diablo coming out? I'll quickly take you back and we'll study it. If you remember, this is where SMAC and Diablo was coming out from the mitochondria. So now they've started asking you in the latest edition of Robbins that this SMAC and Diablo that is coming out, is it pro-apoptotic or anti-apoptotic? So please remember, everything coming out from the mitochondria is pro-apoptotic. When cytochrome C was coming out, that is also a pro-apoptotic molecule. When SMAC and Diablo is coming out, that is also a pro-apoptotic molecule. So the final answer to that is it is pro-apoptotic. Next, they also started doing studies on certain drugs. These are all one-liners which you quickly have to go through in updates. They started asking us how are glucocorticoids and how are sex steroids involved? Glucocorticoids and sex steroids, which of them is pro-apoptotic, which of them is anti-apoptotic, and there's a lot of confusion over it. So I'll tell you what all the standard books and the important books say. Glucocorticoids are pro-apoptotic, glucocorticoids are pro-apoptotic, and sex steroids are anti-apoptotic. Sex steroids are anti-apoptotic. Again, all one-liners, and we'll quickly revise these 5 one-liners which are updates. How many structural details does pro-apoptotic have? Pro has 3, so it has BH 1, 2, 3. How many does anti have? Anti has 4 alphabets, so it has BH 1, 2, 3, 4. How many does stress sensors have? Stress has 3, 3, so there are BH 3 domains. Next, what is SMAC and Diablo? Pro-apoptotic. What is glucocorticoids? Again, pro-apoptotic. The only anti-apoptotic molecule that I have taught you over here are the sex steroids. They are coming under anti-apoptotic. Having said that, we have studied the mechanism of apoptosis. Now we move forward and talk about how to do the identification of apoptosis. So please remember, there will be 2 questions they will be asked to you. The marker and the molecular marker. So remember, the marker is something known as annexin 5. The marker is referred to as annexin 5, and when I say that, there's a very important point that I want to tell you. You'll suddenly ask me that we've studied so much of details of apoptosis and never did I mention annexin 5 anywhere. So what is annexin 5? Annexin 5 is a marker for testing the PS flipping. It is a marker for testing the PS flipping, that is the phosphatidyl serine flipping. So that inside to outside flip that I was talking about, that is tested by annexin 5. I want all of you to be a little cautious, because you know what is going to happen in the exam. Make a table over here and be very, very categorical that you read it very carefully when it comes in the paper. Either they will mark annexin 5 or they will ask you annexin A1. And how will you learn this? Annexin A1 is a marker of hairy cell leukemia. Annexin A1 is a marker of hairy cell leukemia. How did I learn this? I'll tell you. See, when we say hairy, the way you write, it has A1 inside it. Hairy basically has A1 inside it, AI. So that is how I learned it, that hairy cell leukemia is A1. And apoptosis is AP, that is annexin 5, annexin penta. So apoptosis is going to be annexin penta. That is how I learn it. So A and P, annexin penta for apoptosis, and hairy cell leukemia has A and 1, so annexin A1 for hairy cell leukemia. Okay, but if I change the question, this was the marker, very good, but if I ask you the molecular marker, as soon as I add the word molecular, I am wanting to ask you some CD marker. Which CD marker was I talking about in apoptosis? It was CD95 or FAS. And in which pathway did we have? The extrinsic, the outside wala pathway, that was the CD95. So can I say this is the molecular marker only for the extrinsic pathway? Coming to the next, microscopic examination. No point writing all this. Might as well look at it directly as an image. That will make more sense. So when we talk about apoptosis, this picture is very, very important. So all of you are going to look at this one cell over here, which is looking very different from all the other cells around it, right? So what is so different about it? So you're going to tell me 3 points that make it different. Firstly, compare, like look at, for example, look at this cell in the vicinity and then look at this cell over here. Has the cell undergone shrinkage? Yes. There is something known as cellular shrinkage, and I want all of you to be very alert over here, because initially when I was telling you reversible cell injury, or even till I told you necrosis, the cell was becoming a water balloon. The cell was always showing you cellular swelling. And now when I'm talking about apoptosis, I am very clearly telling you that there is going to be cellular shrinkage. That's a very important question that you have. So in all the early stages, the cell becomes a big water balloon, but in the late stages, like apoptosis, the cell is going to shrink. Then look at the color. How is the cytoplasm looking? Obviously, look at the cytoplasm color. It's looking very, very pink. It's looking very, very pink in comparison to the surrounding. It's looking very pink. Look at the color of the nucleus. Look at the color of the nucleus. That is also looking very, very blue. It's become extremely blue. So why has that happened? So look at this, the cytoplasm, compare it with the surrounding. The cytoplasm over here is very, very pink. Compare the nucleus with the other nucleus. See, the other nucleus over here is so light, whereas the nucleus over here is so dark. Why has the nucleus become so blue? Because now you will look at it under the black and white picture. What is this black and white picture? It is an electron microscope, right? And please remember, under electron microscopy, I can see these black clumps. I can see something is getting deposited on the sides, like very black things. That is because the nucleus shows you NCC, nuclear chromatin condensation. Nucleus shows you nuclear chromatin condensation. That is what is important. Okay, having said that, please remember in terms, let me show you one more picture. This also you will be able to identify. Look at all this. Suddenly the nuclei have started looking extremely dirty. They're not looking like regular nuclei. Look at the nucleus. Is it showing you, look at this for example, you'll realize that all of a sudden if I look at this cell or I can look at this cell, the nucleus is showing me those condensed, tiny groups are forming. Tiny groups are forming in the nucleus. So that means that is the hallmark. So if someone asks us that what is the most important point that you have regarding apoptosis, and that is NCC, that is nuclear chromatin condensation. Okay, moving on, but there's a little bit of a difference if I talk about apoptosis happening everywhere in the body versus I talk about apoptosis happening in the neurons. वो थोड़ा सा different है. That you need to be very, very clear about. So whatever apoptotic bodies I was talking about was in general. But if I ask you, what is going to be the hallmark of neuronal apoptosis? Means the apoptosis happening in the neurons. And please remember, that is AIF. Now, I'll tell you what was the main definition of apoptosis that I taught you? I told you apoptosis, caspase dependent. Caspase 8, 9, 10, 3, 6, 7, all about caspase and caspase. But the problem is that neurons do not have caspases. Big problem. God has not given any caspase to the neurons. How will the neurons carry out apoptosis now when God has not given it any caspase? When God closes one door, He opens the other, giving you a life lesson also. So just because it didn't have caspases doesn't mean that it will never carry out apoptosis. It will. How? Because God has given it apoptosis inducing factors. God has given it AIF, apoptosis inducing factor. So if someone asks you, caspases are important for the apoptosis of everywhere in the body, but when we are talking about the neuronal apoptosis, what is neuronal apoptosis going to have? The apoptosis inducing factor. That is the hallmark of neuronal apoptosis. Coming back, the diagnostic part is not over. Is there any stain that we can use? Yes, there's a very important stain called tunnel stain. Now, there will always be some students who really like to ask full form. So, for you guys, I will tell you what the tunnel stain has and then I'll later on come back to the other steps. So, remember, what is tunnel stain? Tunnel stain is TDT, DUTP, nick end labeling. Do you wish to learn it? There is no need to learn this, but yes, just read it once, because just in case the examiner says, I am giving you TDT, DUDP, nick end labeling, at least your mind should be able to club all these words and get you that, yeah, tunnel word was written. Please remember, tunnel is going to be positive in which cell death? Tunnel stain is positive in apoptosis. And look how I'm writing it, that is your mnemonic. And where is it negative? Tunnel stain is going to be negative in necrosis. Repeating once again, you have PO in apoptosis, so it is PO in positive. Positive in apoptosis. Same way, where is it negative? You have NE in negative, so you have NE in necrosis. So tunnel staining is positive in apoptosis, negative in necrosis. Coming to the last method of identifying, and what is the last method going to be? The very, very famous gel electrophoresis. Which gel electrophoresis are we talking about? The DNA gel electrophoresis. So what have I done? There are three people, patient A, patient B, and patient C. I have kept the DNA of patient A over here, DNA of patient B over here, and C over here. I realized that the DNA of this first patient, it remained as it is, like a clump, like an intact clump. Because does he have any cell death? Is the nucleus breaking? No, this is a totally normal person. So person A is totally normal. Next, in the other two people, in person B, I realized the DNA is traveling and it is showing me the very, very famous step. So in person B, I realized that I'm seeing the step ladder pattern. Exactly. I'm seeing the step ladder pattern. Then I went to person 3. In person 3, I realized that I am again seeing that the DNA is going all the way up till end, but continuously. There is no step. It's going like smudged of ink, like ink is getting smudged right till the end. So what do I call this? This is referred to as the smearing pattern. And now the story comes, what is seen in what. So remember, first I'll tell you the most important thing. So if you have to write it in the exam and if you want to learn it as a one word, step ladder pattern is very, very important for apoptosis, and the smearing pattern is very, very important for necrosis. That is how most of the books have written it. So this means this person B showing you this step ladder pattern, what is he suffering from? Apoptosis. Person C showing you smearing pattern, what is he suffering from? Necrosis. But then a question came in the paper, are these specific? No. Is step ladder pattern only seen in apoptosis or also seen in necrosis? And that is the twist in the story. Step ladder pattern is seen in both. I'm telling you this question again. If they give you a question, step ladder pattern is seen in necrosis or apoptosis or both, remember both. But if they ask you which is the best answer, which is the most common, then you will answer apoptosis. And now all of you are going to tell me the reason also. Why does apoptosis show you this step ladder pattern, guys? This I have taught you all the way back when we were studying 180 cut, 180 cut. Why are these? So actually these chota patterns that you're seeing, these small steps that you're seeing, these are 180 base pairs. So can I say the reason or the enzyme that is causing step ladder pattern is the endonuclease enzyme? That was the reason. Everyone remembers? Endonuclease enzyme is responsible for the step ladder pattern. Repeating 180 cut, 180 cut, 180 cut. Yes? Okay, all said and done. Finally, coming back, when someone asks me how do I do the diagnosis, number one, what is the marker? The marker is annexin 5, annexin penta for apoptosis. Molecular marker is CD95. The hallmark is nuclear chromatin condensation. Tunnel stain in apoptosis, PO, is positive. And what is the gel electrophoresis for apoptosis most commonly going to show you? The step ladder. But can step ladder also be seen in necrosis? Yes, it can. That wraps up our entire discussion of apoptosis. So the two cell deaths which are known anyway to everyone, necrosis and apoptosis, finally come to an end. And now we'll be starting with the newer cell deaths, that is necroptosis and pyroptosis.